Welcome to the Brains on Brains podcast, brought to you by ECNP, where early career scientists speak with the most interesting experts in applied and translational neuroscience.
Hi everyone, my name is Michele De Prisco. I'm a psychiatrist and researcher at the Bipolar and Depressive Disorder Unit of the Hospital Clinic in Barcelona, and I will be hosting today's episode of the ECNP podcast, an initiative by the ECNP designed to inspire, inform, and share personal experience in neuroscience research. I'm honored to welcome Professor Marco Solmi from Ottawa in Canada. Professor Solmi is a psychiatrist and researcher at the Ottawa Hospital Research Institute and an associate professor of psychiatry at the University of Ottawa. His work focuses on bridging the gap between evidence and clinical care for mental disorders with a methodological emphasis on meta-research and cohort studies. Since 2014, he has co-authored over 500 research publications. And in addition to his involvement in several international associations, Professor Solmi serves as chair of the ECNP Physical and Mental Health Network, where he leads an international team dedicated to addressing the physical health challenges faced by individuals with mental disorders. Marco, it's a real pleasure to have you with us. Thank you so much for being here.
Thank you so much, Michele, for inviting me. It's a pleasure to be here with you and in the ECNP podcast.
Thank you. Before we get into today's topic, which is the role of meta-research and evidence synthesis in clinical decision-making, I'd like to start with your personal journey. What first got you interested in psychiatry, and how did that curiosity turn into a passion for research?
Well, this is a long story, but I'll try to make it short. Essentially, when I was 18, completed high school, I did a volunteering journey in some foster family context in Peru, in South America, and I met many people that were, struggling for many reasons, physical health included. But what was kind of resonating more with me was more the mental health struggles that some kids and younger adults were going through. And so that's where I decided to choose psychiatry as a clinician.
Nice. And you're currently based in Ottawa after having trained and worked in Europe for many years. And how has working across different research systems and clinical cultures influenced your approach to psychiatry? And
yes, you're correct. I trained in Italy and then I moved to Canada in 2021. So now it's around 4 full years. And I think having worked in different contexts with different also legal contexts, in particular around the Mental Health Act, as well as different system settings with both countries, I have to say, have a public universal system, but there are indeed differences depending also on the geographic characteristics of each country, how densely populated each country is. I think what strikes me as the most important piece in psychiatry is continuity of care. So where I see issues occurring is where there's no continuity of care. And also where there are silos, that's a problem. I think systems and hospitals and services should work as a team in the best interest of the patient. On the other hand, it's also very important to have hubs with vertical expertise, in-depth expertise, specialist expertise in specific areas. But those should be a kind of step 2 or step 3. What is most important, I think, is having access to care. And so continuity of care and access to care are the most important pieces in mental health treatment, in my opinion.
Okay, it's very nice that moving around different settings actually allows you to gather different points of view and so build also a more informed vision of the field. But according to my information, 2021 was just not the year in which you moved to Canada. It was also the year of one other of your many achievements, which is the co-leading of the ECNP Physical and Mental Health Network, which you co-lead with Katharina Hartmann. And the group now includes over 20 members, myself included, as I was fortunate to join as an early career researcher. What gave you the idea to create this network? Because as psychiatrists, sometimes we focus so much on the mental health aspects that we forget that health is also physical.
Yes, essentially, I see myself as a clinician who chose to do research as well, but I'm a doctor, first of all. And so when I see my patients, I do see that they're struggling with their health in general. I think there is kind of an artificial division between mental and physical health. But we actually, at the end of the day, have only one health. If we're not doing well physically, we will not be doing well mentally, and vice versa, most likely. So I thought that creating a network with a set of multidisciplinary professionals with different backgrounds and different skills, different clinical skills, as well as a research um, background, I think could serve our clinical population. And why am I saying so? Is that probably it's very, very important to identify disparities in how people with mental disorders are treated for the physical health conditions. And having a group, international group, focusing on this is probably, we hope at least, trying to generate more awareness of the gaps in physical health in people with mental disorders, ideally identifying also actionable items that ultimately reduce the gap in mortality and morbidity in people with mental disorders.
Thank you. I totally agree with your point, and I totally agree that policies, countries, and also individuals should more focus also on medical aspects. But let's talk a bit about your current work now. What are some of the main research questions that you're focusing on right now?
Yes, thank you, Michele. This is a very relevant question for me because I've always tried to focus on one specific theme, but I'm naturally drawn into many different directions. And that's because I work also as a clinician. So I do see clinical questions and things that are very important clinically that I want to address with the research that I do. The type of research that I do is not as pros and cons. I do a lot of work with evidence synthesis and secondary data. So the pros are that theoretically I can quote unquote quickly, depending on the size of the project, but try to summarize evidence and try to answer some questions. What's the evidence on this question? What's the evidence on that question? Using data that are already available. And then another thing that I do is using real world databases, representative databases, to generate evidence on the contemporary outcomes and consequences of, let's say, for instance, policy making or let's say monitoring the changes over time of, let's say, trends of substance use in mental disorders and so on. And so the main direction that I'm taking now with my research is trying to bridge the evidence, the gap between evidence and clinical practice. Why and am I doing so? Because I see in clinical practice there's still a lot of non-evidence-based practice, unfortunately, and the reason for that is that clinicians, they know exactly what they're doing. They're very good doctors, and I know very good clinicians and colleagues. The problem is that they're not updated with the most updated evidence. And why? Well, because the evidence is too fast. The evidence keeps changing, a lot of new studies, a lot of new meta-analysis. And so what we're trying to do now is we have created a framework, research framework that is called the UREACH, which stands for Umbrella Review, Evaluation, Assessment, and Communication Hub, which is a set of transdiagnostic living umbrella reviews with associated online platforms, digital tools that make the evidence available following open science principles to anyone, the general public, clinicians, researchers, regulatory agencies. We've also shared decision-making tools that can inform clinical practice or even education for a younger generation of a mental health professional. Just imagine, we completed a chapter of this UREACH approach with on bipolar disorder. You are the first author of that project, so you know that very, very well. And you have seen how we can summarize evidence from over 3,000 data points from RCTs on bipolar disorder, any stage, any intervention, any control group, any outcome. In just a couple of clicks, the user of the platform can just narrow down to a specific clinical question and have a visual representation with also lay language summary of, say, 2, 6, 10 data points. So these tools are incredibly powerful, and I believe they are definitely the future of evidence synthesis. I think static papers or static papers, I think the kind of probably the past, and the future needs to go, needs to see editors and publisher going hand in hand with these kind of digital platforms to stay up to date.
Yeah, totally, for sure. And you spoke about evidence synthesis, you spoke about meta-research, but sometimes when I speak with people who are not familiar with this term, they quite do not understand what does actually meta-research mean. Would you like to explain what meta-research evidence synthesis actually means for people who may not be familiar with these terms?
Yes, of course. I also face this situation frequently. So meta research is, if you want, research on research. And so it's a meta level of research where the focus is on how research is conducted, what are the methodology issues, what are the strengths of this or that type of research, how research is reported, what are the sources of bias, where's the room for improvement, what's the trend of research in a given field. And so overall, it's very important to see where the field is moving. And why is that important? Well, it's very important because we see a lot of, let's say that the evidence is what is published out there. Okay, so that's the evidence that comes to our attention. Okay, but the reality of things is that there is a lot of research that is going on that is not necessarily published, and there is a globally a tendency and a push to publish significant findings. And so this is very important to keep in mind. So when we read something, we're probably reading one of many studies, and not all those studies have been published. And most likely what we see in a journal is a fraction of what is going on. And the studies that do not show, let's say, a significant effect of a given medication are the studies that typically are not published, or of a given intervention of any kind, brain stimulation or psychosocial, psychotherapy, or whatever kind of intervention. So by doing meta research and evidence synthesis in general, you become more and more aware of this situation. And so, for instance, when you look at the evidence on psychedelics, this is another good example. We have seen a lot of meta-analysis that reported effect sizes as large as 1.8, 2, these kind of effect sizes, and which are hardly credible, right? And the reason for those effect sizes are maybe that, well, maybe there were some computational errors in the meta-analysis, but maybe it's also because the studies are very biased. And so by doing a lot of evidence synthesis and meta research, you become more and more aware. I've been doing this since I started day one, my research activity, and it's been the most exciting and I would say eye-opening learning experience that I, by the way, keep learning with. I keep realizing that there are issues in how research is conducted, including the research that we do. We keep improving. We keep updating the methodologies. And this is very, very important because ultimately the research that we do can touch many lives. We influence guidelines. We influence how clinicians work in the mid-long term. And so we have the responsibility to make sure that we publish estimates, data that are credible and solid.
Yeah, it's a very big problem because meta research allows us to actually make sense, I believe, of science. Also because I remember that when I started doing research in 2021, I had no idea on how to properly search PubMed. So, for example, I just typed bipolar disorder, title and abstract, and got around 27,000 results. And I remember that I did the same thing while preparing this interview, and I got 38,000 results. So I believe that in 5 years, we have more than 10,000 papers more, which is like something very hard to actually take care of. And maybe with meta-research, maybe with living reviews or those projects that you were referencing about before, maybe we can actually be more close to understanding.
Yeah,
So,
I hope I hope so, Michele. And I give you an example of how we're using the bipolar disorder UReach platform. So I've been involved in the update of the CANMAT guidelines for bipolar disorder, and that behind the CANMAT guidelines, there is a very, very rigorous process in terms of reviewing the literature, in terms of interpreting the literature as well. And so where the platform turned useful was that we were quickly able to answer, well, I mean, should we update this level of evidence for this medication? Is the new meta-analysis on this? So what were the trials included in this meta-analysis? Do we really trust this meta-analysis estimates? And so what I was able to do live was, trying to answer this question, just browsing on the platform and identifying the most updated or the largest meta-analysis on this or that intervention and clinical outcome. And then, of course, these type of platforms do not replace guidelines. Guidelines are made with kind of an additional step. So again, meta-analysis do not tell the whole story. That's a statistical exercise, but I mean, you need to interpret evidence with a very, very critical eye. You need to know the literature. You need to have clinical expertise to be able to interpret the RCTs, and that only then you can actually do guidelines. So that's what's happening with the CANMA guidelines. A lot of very knowledgeable people, both methodologically and also in clinical in bipolar disorder, ultimately drafted the final CANMA guidelines for bipolar disorder. But that's been a very good example of how this UReach framework and this new direction that we're taking can actually help moving the needle in clinical care for our patients.
Okay, and I believe that I already know the answer for this question, but I would like to see your perspective about this. How long does a meta-research project usually take? Because some people assume that maybe since you're working with already collected data, it's a relatively quick process. But I've always thought of meta-research like as a kind of an ecological approach, like second-hand clothing, in which we reuse what's already out there. And do you think it's possible to generate truly new knowledge from existing data and giving them a fresh life and a new perspective?
Well, I think depends on what we mean by knowledge. No, we cannot generate new data with meta-analysis, but we definitely generate new knowledge. I mean, data need to be interpreted and organized to become information and then knowledge. So yes, evidence synthesis can generate new knowledge and new information. And the reason again is what I just said, that you cannot just rely on one RCT or one cohort study. In observational science, it's even more important, right? You need to grade the credibility. We do that regularly with quantitative criteria. You need to, replication is essential in science, and in particular in mental health, where, by the way, our constructs as well as our outcomes are frequently somewhat subjective because we rely on clinical symptoms, clinical assessments, as well as clinical scales, sometimes questionnaires. So obviously there's a degree of imperfection that it's part of the discipline in itself. And so replication is very, very important. So meta research and evidence synthesis can definitely generate new knowledge. If by knowledge we mean something that can update our understanding of how a given medication works or how a given risk factor increases or decreases the risk of a given outcome. Now, to address your question on how long it takes to do a meta research project, well, I can tell you it can take from a month For instance, I did a very quick meta-analysis on CAR-XT. There was not a lot of evidence just because it's a new medication. And so that's been, we focused, organized very, very efficiently with some brilliant colleagues. Nick Fabiano was the one helping a lot with that paper, among others. And so we've been able to do it fairly quickly in a month. But I can tell you that I've been research projects that took me 5 years to complete, and also now that I'm kind of transitioning in my career and I'm kind of becoming more of a supervising role and not necessarily doing everything firsthand as I used to. Now, of course, the skills, the soft skills that I need to use are different. And so I need to have very good organizational skills. I need to have realistic expectations from the team that I put together. I need to make sure that there is a system in place to control quality. And quality is massive. It's actually the most important piece. Speed and how fast you do things is not the most important thing. Quality is the most important thing, both from an ethical standpoint, because we have the responsibility, right, to produce good data, because again, we can impact clinical care. And then also because meta research, it's a learning experience. So what I try to do is to share with my early career trainees and colleagues, trying to show them that quality is very important, and that's the only way you can actually do good research. So again, time depends on the size of the project, the complexity of the project, and never compromising on quality. I think, Michele, also on this matter, it might also be interesting to briefly chat about AI. Not sure if it's something you're interested in, with the role
Yeah,
of AI in systematic
I believe
review.
it's very important to take this into consideration. Do you think that AI actually has a role? Because sometimes, okay, we need to screen text, screen full text, extract data, but sometimes we cannot do this like in a very mechanical way. We need to think about it. We need to criticize every aspect that we see. Do you think that AI tools are actually prepared to, well, if not substitute, maybe co-work with humans on these tasks?
So first of all, I think so AI is already happening, right? And it's already being used for, for instance, manual search. I use it myself for manual search when I need to identify some papers. I use, for instance, Perplexity or ChatGPT, just to speed up the manual search process. But again, every systematic review needs to go through a systematic review process. So with all the steps that are required, AI can now be used to rank the titles and abstract to screen. That's used in Ryan, Covidence, many other softwares. We're also working on developing a software ourselves that does this. I don't think it's ready to do the data extraction. And also because the way data are reported is extremely heterogeneous, and not all the data are always available in the PDF, and there can always be mistakes in how data are reported, and you can only realize that if you look at that with a human critical and very trained eye, as opposed to just transcribing what you read in a PDF. So the data extraction piece, I think, is the most difficult one. I have to tell you, though, that human is not necessarily a good gold standard, because again, quality is extremely heterogeneous, and and so again, it depends on AI can be superior to certain human work, but I think not to high quality human work, and so just to in sum, I think yes, AI is coming. It will be used more and more in evidence synthesis for sure. I know companies that are investing a lot on this, but I think again we're talking about human health here. So maybe can be used very quickly to extract data on, I don't know, accounting things or other aspects or free text. But here we're talking about human health. And so I think we need to be extremely careful. And we don't want to delegate control to AI. We always need to keep control. And by the way, there will always need to be a quality check. So yes, you can speed up things with AI, but then any good researcher or clinician will want to check what AI did. You cannot just be excited because things are done in 1 day instead of 1 year. I mean, you want to be excited because you do a good job, and so you will need to check anyway. So if it's a lot of work, a lot of papers, anyways, you will need to check them. And so I think yes, AI can help a lot, but I don't think it can replace human work, at least to date.
I believe that this is a very good insight for also people that are listening to us, that may have like doubts or concerns about the correct use of AI into meta research. So thank you. And today you are sharing with us a lot of different perspectives, both regarding your professional life and also like some human and personal aspects that made you arrive at your current position, professional life position, and so on. But this is a question that I really enjoy asking because the answers that I get are always so different, often surprising. If you had to name one person, whether it's a researcher, a writer, a musician, a philosopher, artist, whatever you want, who's had a meaningful influence on your career or the way you think, who will it be and why?
I will name two, if I can.
Yes, you can. Yes, you can.
Okay. Okay. Thank you. Very kind. Very generous. So I'll name two. One is Christoph Corral. He's been the person that introduced me to research and the person that again taught me to never compromise on quality and always put the priority again on precision and accuracy over speed. And among many, many other things, I think has been definitely the main mentor that allow me to grow and learn. And then the second person is the person that welcomed me to Ottawa. It's Jas Fiodorovics. He hired me in Ottawa and in Canada, and so he's been extremely generous and supportive, kind of a selfless leadership style that I try to embrace and also integrate in my work with early career colleagues.
It's very nice that you had the luck and the pleasure to meet many people that actually helped you becoming what you are. So we are going to the conclusion of this interview, and today we talked about meta research, not just as a tool to summarize existing knowledge, but also as a way to create new insights, to organize results and evaluate the knowledge. Looking at how do you see the future of this field evolving? Maybe AI, but you already told that it's actually a present thing. Do you think that we are having so much types of meta research? You have systematic reviews, pairwise meta-analysis, network meta-analysis, umbrella reviews. Do you think that we'll keep building new layers, or we will eventually reach a point where we stop?
No, I think we will. I mean, the goal, I think, is so from a commercial standpoint and from a scientific standpoint, I think the goal is to reach as many people as possible, right? I mean, there's kind of a joint direction and priority there. And so companies, AI companies that prioritize a lot, of course, reaching as many people as possible, they would probably have to work with science people to train their model, make sure their models do not, reproduce, do not hallucinate, do not confabulate, do not, tell lies or do not mislead. And so I think we will have I think we're heading towards a universe of an ecosystem of different tools. These can be conversational tools, or can be online digital platform that you can just browse. These probably the main ones. I think PDFs with guidelines will probably be the past. We will still need them even to train models, to educate, to have people learning. But I don't think clinicians will read them, and they currently do not read them a lot. So I think every guideline will need to have an associated digital tool. Again, it can be a digital tool like the Urich one. It can be an AI conversational tool, but that's the direction where we're going. Digital tools bringing the evidence to the doctor office. That's where we're going to.
Okay. Very nice perspective. And let's make a bet. I usually close these interviews with a bet, and we should promise ourselves to come back to this episode in 10 years. Is there an important aspect of meta-research that we are currently underestimating or overlooking? What will we wish we had paid more attention to?
Well, I think open science is probably our biggest regret. I think we're wasting a lot of money, a lot of time, a lot of people time on redoing things. And probably if there was more kind of a system that incentivizes open science, probably people would be more open to share. Currently, throughout the country, the system incentivizes the number of publications. And of course, I always adapt myself to the incentives in the system, in particular in the early career stage, because it's a competitive field. And so you do what you have to do, right, in terms of advancing, of course, your professional performance. But recently I decided to kind of try to take a different direction and again follow open science as much as possible. This is why we built the Urich framework, where you can just download everything that we do for free. Will people give us credit? I don't know. We'll see. Time will say. But I think the biggest regret is that we don't share the data. We should share the data more and more. I understand there are complexities behind these, and commercial complexities and ethical complexities, privacy complexities. Do understand that, but that should definitely be the direction. We're probably sitting on so much data that might even inform us to, might even allow us to do prediction, personalized medicine in psychiatry, but we just don't have access to all the data. And so unfortunately, that's still in the future. So that's, I think, the biggest regret. But things are changing, so I'm optimistic.
Okay, so let's hope to change, to be surprised in 10 years or maybe also in 5 when we will release this podcast. Thank you so much, Marco, for this interesting and enriching discussion. I'm sure that our listeners will find many ideas that will guide their clinical and research work. Many thanks to all our listeners, and be sure to catch future episodes of the ECNP podcast, where we share experiences from leading experts in neuroscience research. See you next time, and thank you.
Okay, thank you very much, Michele. It's been a pleasure, and see you soon.
Thanks for listening to this podcast from ECNP. The views and opinions expressed in this podcast are those of the interviewee and do not necessarily reflect the official position of ECNP. The content of this podcast should not be used in any way as the basis for treatment decisions.